Most of you watching this video right now have been told the same thing by your doctor. Your blood pressure needs to be 120/80. That's the target. That's the goal. And if you're not hitting it, well, we need to add another medication. Maybe two. I spent the first 10 years of my career saying those exact same words to my patients. I believed it completely. The guidelines said it. The textbooks said it. Every conference I attended reinforced it. And then I started noticing something that didn't make sense. I had patients in their 70s and 80s who were hitting that perfect 120/80, and they weren't doing well. They were dizzy. They were falling. One woman fractured her hip because she stood up too quickly and blacked out. Her blood pressure at the time, a perfect 118/78. And I had other patients, same age group, running blood pressures around 135, 140/85, and they were walking 5 miles a day, sharp as a tack, living independently, thriving. So I started asking a question that changed everything. What if the target we've been aiming for isn't right for everyone? What if, for people over 60, chasing 120/80 is not just unnecessary, but actually dangerous? My name is Dr. Adevin. I'm a board-certified physician with over 15 years of clinical experience in cardiovascular medicine, and today I'm going to share what the research actually says about blood pressure targets for older adults. Not what sounds good in a headline, not what makes for a simple one-size-fits-all answer, but what the science shows when you look at real patients, real outcomes, and real quality of life. This might challenge what you've been told, and that's okay. Good medicine should always make room for better evidence. Before we go any further, I need to be absolutely clear about something. Nothing in this video is personal medical advice for you specifically. I don't know your health history. I don't know your medications. I don't know your individual risk factors. This is educational information based on published research and clinical guidelines. Every decision about your blood pressure management should be made together with your own doctor who knows your complete medical picture. That said, the information I'm about to share with you comes directly from major clinical trials and updated guidelines that many patients simply never hear about in a 15-minute office visit. Let's start with where that 120/80 number even came from. For decades, it was based primarily on studies done in middle-aged adults, people in their 40s and 50s. The logic was straightforward. Lower blood pressure meant less stress on the arteries, which meant lower risk of heart attack and stroke. And for younger and middle-aged adults, that logic holds up beautifully. The data is clear. But here's what happens when you apply that same logic to someone who's 75 years old. The body has changed. The cardiovascular system is not the same as it was at 50. The arteries are stiffer. They don't have the same elasticity. The regulatory systems that control blood pressure, the kidneys, the nervous system, the hormones, they all work differently. And most importantly, the risks change. In a 50-year-old, high blood pressure is dangerous primarily because of what it might cause 20 or 30 years down the road. In a 75-year-old, we're not thinking about 30 years from now. We're thinking about quality of life today, this year, and the very real risk of what aggressive blood pressure lowering can do right now. There was a landmark study published several years ago called the SPRINT trial. It made huge headlines because it showed that targeting a systolic blood pressure below 120 reduced cardiovascular events compared to a target below 140. The medical community took notice. Guidelines started shifting. Doctors began pushing for tighter and tighter control. But here's what most of those headlines didn't mention. The SPRINT trial excluded some of the most vulnerable elderly patients. It excluded people with diabetes. It excluded people with prior stroke. It excluded people who were frail or living in nursing homes. And even within that selected population, the group aiming for below 120 had significantly higher rates of serious adverse events, kidney problems, electrolyte imbalances, dangerously low blood pressure, and falls. When researchers later analyzed the data specifically for adults over 75, the benefits became much less clear, and the harms became much more significant. This is not a fringe opinion. This is what the data shows when you look carefully. Around the same time, another important study called the HOPE-3 trial looked at blood pressure management in older adults with moderate cardiovascular risk. What they found was fascinating. For people who started with blood pressures in the 130s and 140s, aggressive lowering didn't provide the benefit researchers expected. In fact, for some groups, it provided no measurable benefit at all while increasing side effects. Then there's observational data from large populations of elderly patients followed over many years. Some of these studies found what researchers call a J-shaped curve. That means that both very high and very low blood pressure were associated with worse outcomes, and there was a sweet spot in the middle. For many patients over 70, that sweet spot wasn't 120 over 80. It was somewhere between 130 to 145 systolic. Now, does that mean everyone over 60 should be aiming for 140? Absolutely not. Medicine doesn't work that way. But it does mean we need to stop treating every older adult like they're 50 and start asking what target makes sense for this specific person. Let me tell you about a patient I'll call Margaret. She came to me at 78 years old, frustrated and exhausted. She'd been seeing her previous doctor for years, and every visit was the same conversation. Her blood pressure was 138 over 82, and he wanted it lower. He kept adding medications. By the time she came to me, she was on 4 different blood pressure pills. Her pressure had come down to 122 over 76. Perfect, right? Except she could barely get out of bed in the morning without feeling lightheaded. She'd stopped going to her book club because she was afraid of falling. She told me, and I'll never forget this, she said, "Doctor, I feel like I'm fading away." We sat down and went through everything. I looked at her kidney function, her electrolytes, her history. She had no history of heart attack or stroke. Her main risk factor was her age and mild high blood pressure. I made a decision that some doctors might have questioned. We reduced her medications, slowly, carefully. We stepped her down. Her blood pressure settled around 135 over 80, and Margaret came back to life. She started walking again. She rejoined her book club. 6 months later, she told me she felt better than she had in 3 years. Did we cure anything? No. Did we optimize her individual care? Absolutely. Now, let's talk about what the current guidelines actually say, because this is important. The American College of Cardiology and the American Heart Association updated their guidelines to recommend a target below 130 over 80 for most adults, including older adults. But, and this is critical, those same guidelines explicitly state that treatment should be individualized. They acknowledge that for older adults, especially those with limited life expectancy, frailty, or multiple health conditions, a higher blood pressure target may be more appropriate. The European Society of Cardiology goes even further. Their guidelines specifically recommend that for adults over 80, systolic blood pressure targets can reasonably be in the 130 to 139 range, and treatment should prioritize avoiding side effects like dizziness and falls. These aren't rogue opinions. These are mainstream medical organizations saying what many clinicians have observed. One size does not fit all. So what does this mean for you? It means that if you're over 60, the conversation with your doctor should not be about a single number. It should be about you, your overall health, your other medical conditions, your risk of falling, your kidney function, your quality of life. Let me give you some specific factors that should influence your blood pressure target. First, frailty. If you're independent, active, and robust, your body can likely handle and benefit from tighter blood pressure control. But if you're frail, if you've lost significant muscle mass, if you tire easily or have a history of falls, aggressive lowering can be genuinely dangerous. Second, kidney function. The kidneys regulate blood pressure, and blood pressure affects the kidneys. It's a two-way street. If your kidney function is already declining, overly aggressive blood pressure medication can make it worse. Third, cognitive function. There's emerging evidence that very low blood pressure in elderly patients might be associated with reduced blood flow to the brain, which can contribute to cognitive decline. The brain needs adequate perfusion. Fourth, medication burden. Every medication you take is another pill to remember, another potential side effect, another interaction to worry about. If you're already on 8 or 10 medications, adding 2 more blood pressure pills to chase a number that might not even benefit you is worth questioning. Here's a framework I use with my own patients. If you're over 60 and your systolic blood pressure is consistently above 150, that's generally too high, and treatment is almost always warranted. The risk of stroke and heart problems at that level outweighs the risks of treatment for most people. If your blood pressure is below 120, especially if you're on multiple medications to keep it there, we need to have a conversation about whether that's too low and whether you're experiencing side effects that are being overlooked. And if you're in that middle zone, 130 to 145, that's where the conversation gets individual. We look at everything else: your history, your symptoms, your goals, your lab work. There's no automatic answer. And that's actually a good thing because it means we're treating you as a person, not as a number on a chart. Let's talk about what happens when blood pressure goes too low, because this is the part of the conversation that gets skipped in a lot of offices. The medical term is hypotension, and in older adults, it can be serious. Orthostatic hypotension is when your blood pressure drops significantly when you stand up. Normally, your body compensates instantly. Your heart rate increases, your blood vessels constrict, and your blood pressure stays stable. But in older adults, especially those on multiple blood pressure medications, that compensation doesn't happen fast enough. You stand up, your blood pressure drops, blood flow to the brain decreases, and you get dizzy or even pass out. Falls in older adults are not minor events. A hip fracture at 75 can mean the end of independent living. It can mean surgery, rehab, complications, a cascade of problems. And if that fall happened because we were chasing a blood pressure number that was never right for that person in the first place, that's a tragedy we could have prevented. There's also something called excessive blood pressure variability. Some patients have blood pressure that swings wildly throughout the day. It's 160 in the morning, 110 in the afternoon, 145 in the evening. If we dose medications based only on that 160 morning reading, we might be causing dangerous lows at other times of day. This is why home blood pressure monitoring is so valuable. It gives a complete picture, not just a snapshot in a stressful doctor's office. And speaking of the doctor's office, let's talk about white coat hypertension. It's real, it's common, and it leads to overtreatment all the time. Your blood pressure at home is 128/78, perfectly reasonable. You walk into the doctor's office, you're a little anxious. Maybe you rush to make the appointment, and suddenly it's 148/88. The doctor sees that number and wants to add medication. But that number doesn't represent your actual day-to-day blood pressure. It represents your stress response to being in a medical environment. This is exactly why home monitoring and sometimes 24-hour ambulatory monitoring are so important for making good decisions. Now, I want to address something I see all the time in the comments on videos like this. Someone will say, "My doctor won't listen to me," or "My doctor just wants to prescribe more pills." I understand that frustration. I really do. But I also want to offer a different perspective. Most doctors are not trying to harm you. They're working within systems that give them 15 minutes per patient, insurance companies that demand documentation of specific targets, and guidelines that, until recently, really did push for lower and lower numbers across the board. What I want to encourage you to do is bring information to the conversation. Print out the guidelines that mention individualized care. Ask specific questions. Not confrontational questions, but collaborative ones. "Doctor, I've been reading about blood pressure targets for older adults, and I'm wondering if my current target is right for me, given my age and health status. Can we talk about the risks and benefits?" That opens a door. It invites a real conversation. And if your doctor is dismissive, if they won't engage with that question, then yes, it might be time to seek a second opinion. You deserve a doctor who treats you as a partner in your care. Let me give you 5 specific questions you can ask at your next appointment. First, what is my specific blood pressure target? And why is that the right target for me at my age and with my health conditions? Second, am I experiencing any symptoms that might be related to low blood pressure, like dizziness, fatigue, or trouble concentrating? Third, have my kidney function and electrolytes been checked recently, and are they stable on my current medications? Fourth, would home blood pressure monitoring give us better information than office readings alone? And fifth, if we reduced my medications, what would we be watching for, and what would be the actual risk? These questions demonstrate that you're informed, engaged, and reasonable. They're not accusatory, they're collaborative, and they give your doctor the opportunity to explain their thinking, which might reassure you, or they might realize they haven't fully considered your individual situation. Here's what I hope you take away from this. Blood pressure management is important. I'm not telling you to ignore high blood pressure. Uncontrolled hypertension causes strokes, heart attacks, kidney failure, and vision loss. It's serious, but the goal of managing blood pressure is not to hit a specific number on a chart. The goal is to reduce your risk of bad outcomes while maintaining your quality of life. For some people over 60, that might mean aiming for 125. For others, it might mean 138 is perfectly appropriate. The difference is not laziness or lack of care. The difference is individualized medicine, which is what good medicine has always been supposed to be. We have better data now than we've ever had. We understand that older bodies are different. We know that frailty matters, that kidney function matters, that fall risk matters. We know that medication side effects are not just minor inconveniences. They're real factors that affect real lives. I started this video by telling you about patients who were doing poorly at 120/80 and thriving at 135/85. That's not a contradiction. That's biology. That's the complexity of human health. And it's a reminder that medicine is both science and art. The science tells us what works on average in large populations. The art is applying that knowledge to the individual person sitting in front of you. You are not a population average. You're a person with a unique body, unique history, and unique needs. Your blood pressure target should reflect that. If you're over 60 and you've been struggling to hit 120 over 80, if you're on multiple medications and feeling worse instead of better, if you're dizzy or tired or just not yourself, please have this conversation with your doctor. Bring these questions, bring this information. And if your doctor is good, and most of them are, they'll welcome the conversation. Before I close, I want to leave you with something hopeful. We are living in the best time in human history to be an older adult with high blood pressure. We have more medication options than ever. We have better monitoring technology. We have stronger evidence about what works and what doesn't. And we're finally starting to move away from rigid, one-size-fits-all approaches toward truly personalized care. That's exciting. It means your blood pressure can be managed in a way that fits your life, not a way that makes your life fit around a number. It means you can be healthy and feel good, not just have good numbers on a chart. So if there's one thing I want you to remember, it's this. The goal is not 120 over 80. The goal is you living your best, healthiest, most vibrant life. And sometimes, for people over 60, those two things are not the same. I'd love to hear from you in the comments. What's your experience been with blood pressure management? Have you felt pressure to hit a certain number? Have you experienced side effects from medications? What questions do you wish your doctor would ask you? Let's start a real conversation down there because I read every comment, and your experiences help other viewers realize they're not alone. And if this video gave you information you haven't heard before, information that might help someone you care about, please share it. Send it to a friend, a family member, someone who might be struggling with the same questions. That share might be the thing that helps them have the conversation they've been needing to have. Thank you for watching. Thank you for being engaged in your own health. And remember, good medicine is a partnership. You bring your experience, your symptoms, your goals. Your doctor brings knowledge, evidence, and expertise. And together, you figure out what's right for you. Take care of yourself. Ask the hard questions, and never be afraid to advocate for care that makes sense for your life. I'll see you in the next video.